Hey, it's Dr. Centeno, and I've got a new time here, so we'll have to see how many people show up. I know I've been moving the time around a little bit, really trying to get a little bit better work-life balance. I'm one of those guys that is as likely to be working usually on a Sunday morning or a Saturday afternoon as I am during the week. So trying to get better at that. So I'm trying to move things around. I looked and there were a lot of people online on my channel, my YouTube channel during this time. So we'll see how this goes. And today we're going to talk about which imaging is needed to diagnose CCI. Now, I've talked about this before, but I've tried to condense some of this information. I have a couple different videos on this topic, but I've never done one that's very, very condensed to try to help people relatively quickly get to an answer here, because this is a common question I see, right? People come to me all the time. Which imaging test should I do? This is the one I have. Is it good enough? Etc. So we're going to go through this today to try to help patients navigate this imaging maze. And again, we'll do Q&A. So after this short lecture, I'm going to do questions and answers. One of the things I really recommend is if you have a question, get it in the comments now, because that way I'll get to it, because frequently I just can't get to all of them. I'll leave a good 10 or 20 unanswered by the end of the hour. And today I think we're going to go about 45 minutes or so. So try to make sure to get your question in early. And again, today we're talking about which imaging test is needed to diagnose CCI, and try to condense this information because this is a common question that I get from patients. So let's get into this here. And then at the end of that, we'll do Q&A. Again, get your questions in now, because if you don't, oftentimes I can't get to all the questions. And I feel like I disappoint some of the patients, but that's why you got to get them in early. So let's start this. Which imaging test is needed to diagnose CCI? So there's some common rules here that we're looking for in imaging tests for CCI. The first biggest rule is that we need movement-based imaging. That is critical. So if you bring me something like a static CBCT from your local upper cervical chiropractor, that doesn't help me diagnose CCI. Or if I've got a static live face up in a tube MRI, again, not that helpful because there's no movement component. The same would hold true for just sort of static x-rays. So the first rule is movement. And as a corollary to that rule, it's maximum movement. So if we were going to look at a CBCT, great, it should have flexion and extension. But the problem with CBCT is it's got a limited field of view. So frequently there'll be a maximum range for flexion and you'll have to stop against something, and a maximum range for extension and you'll have to stop against something. Not ideal for detecting craniocervical instability and movement-based imaging in general. Second big rule is upright positioning when possible. So you want to make sure the patient is in their natural gravity-bearing environment, right? That's very, very critical. So a DMX fits that. Usually a CBCT, but again, usually has limited flexion and extension. Another thing that fits that would be an upright MRI. Now, compare and contrast that to a live face up in a tube MRI. Now we don't have any natural gravity, right? And then make sure that you've got the right views is the third rule. For upright MRI and DMX, that's flexion and extension. And then DMX adds that additional piece of open mouth, lateral bending, left and right, where we're looking at C1, C2. Doing that with a DMX makes sense, or even doing that with an X-ray makes sense. Doing that with an upright MRI, sometimes I'll see some of the German MRIs that have sort of lateral bending views. in my experience, doesn't work as well simply because it's hard to push it to its limit because it takes a while to get the picture to form in an MRI. So it's hard to keep the patient in that position. Whereas if you're doing DMX, they're just over there for a second and then they come back. If you're getting an MRI, make sure it's got complete coverage of the craniocervical junction. And that's a key point, right? Because at the end of the day, the standard MRI is really just looking from about C2 down to T1 or 2. It does not include this upper cervical MRI or this upper cervical region. So make sure that you understand that while some of the cuts on a routine live face up in a tube MRI will show through the craniocervical junction, many of the more detailed cuts axially, meaning, sawing in half view, won't be there because they don't go high enough. So if we're looking at something in the craniocervical junction, you got to make sure that they're going to go all the way up from C2 to the skull base. And then obviously you want a center that's familiar with what it is we're looking for, right? That's going to be a center familiar with CCI imaging. So what types of CCI can each test detect? And I'm going over DMX and upright flexion extension MRI. DMX is best for types 1A, 2B. So let's go through that again. 2A, 2B, 3A, 3B. So for type 2A, that's when you're going in flexion and you're seeing opening of the atlantodental interspace between the dens and the atlas due to a loose transverse ligament. For type 2B, that's the side-to-side type instability at C1, C2 that we're seeing that we call overhang on a DMX. Type 3A is where C2 moves forward on C3. Type 3B is where C2 moves backwards on C3, forward with flexion, backwards with extension. So those are the kinds of instability that you can see well in DMX. Now notice there's no type 1s in here. DMX is not that great for looking at type 1 instability. Type 1 instability is going to be C0, C1, right? So we can see some things going on with C0, C1 on DMX, but it's very hard to measure because of all of the overlapping shadows that are inherent in X-ray. Then we go to upright flexion extension MRI. Where does it really shine? And it really, really shines in the type 1s. So the most common type 1s out there are type 1A. That's where the head rotates too far forward and we get that very low clivoaxial angle. Another area where it shines is type 1C, and that's where you got the sliding motion happening at the skull relative to the neck. Now there are other types there, type 1B, too far back this way, type 1D, rotational, type 1E, vertical, but I'm just talking about the most common ones here. But DMX doesn't do well with those type 1s, whereas upright flexion extension MRI does do well with those type 1s. Now, sometimes on upright flexion extension MRI, you can see other things, right? You can see a 2A, where you get opening of that atlantodental interspace in flexion, but it's not going to be so sensitive for that because you don't have as much pushing towards the end range as you do in a DMX, because that's one of the inherent problems with an MRI. It takes a while to get the picture, so it's hard to keep the patient in that position long enough to see what you need to see. And you can also see type 3A and 3B, which is C2-3 moving or sliding forwards and backwards. That one is a little bit more present on an upright MRI. I see that one all the time. But again, not going to be as sensitive as a DMX for those things. So in summary, DMX tends to diagnose more types of CCI at C1, C2, and C2-3 more accurately, or it's got higher sensitivity. Upright MRI is more focused on that type 1 instability. That's where it's highly sensitive. So that gives you an idea of what's doing what. And then a common question I get is, should older imaging be repeated, right? A patient comes in with a MRI from 18 months ago or a DMX from last year. And the answer usually is, listen, if it's very old, 3, 4, 5, 6 years, then we're probably going to want to repeat it. But if it's been done in the last 2 years, and on top of that, there really hasn't been a dramatic change in your symptoms, then we're probably not going to repeat it. Now, if it's done last year and there's been some dramatic change in your symptoms that we want to make sure there's nothing new, then we will repeat it. And again, another thing that we often repeat on the MRI front is if it's not a dynamic or movement-based study. So if so, we've got to get one. And sometimes there's poor quality or there's quality issues on the MRI. So that would be another reason why we might want to repeat the image. But the bottom line is we repeat the study if we think we're going to get some clinical information out of it that might change that decision matrix. I often tell patients we shouldn't be doing studies if it's unlikely to change what our game plan is for you. And another big one I get is, what if there's no local upright MRI? What if there's no local DMX? Much more common, no local DMX where you are. Well, one of the things you can do is to replicate a DMX type view with a routine X-ray. I've got a whole video, if you go to my YouTube channel and look that up. And I think the key to finding it there, because I've got like 1,000 videos or something, is type in DDR. DDR is a type of dynamic X-ray, dynamic digital radiography. But type in DDR if you want to find that particular video. But that video is made so that a X-ray tech or a physician can look at it and get an idea of what we're looking for. And I have now diagnosed CCI on many of those sort of faux DMXs that we get using routine X-ray equipment in countries where there is no DMX. So that's one thing to consider. Another thing to consider is that you can do DMX at Centeno-Schultz. So it just means that we may not know what it is you're going to get, whether it's procedure A, something like advanced posterior injections or a PICL, but we can make that determination at a later date during your visit, because we'll start with the DMX and then go from there. Now, you'll be in a flexible slot, which means you probably won't be on my schedule. Since I'm only in the office 2 days a week right now, I only do the PICL procedure. So that flexible slot will mean that you'll be on Dr. Schultz's schedule, Dr. Pitz's schedule, or Dr. Merkel's schedule. Okay, well, I think that's it. Now is a good time to start to take questions because I see those piling up here. Let's go back to this type of format, and we'll start with the first one. Vero, hello, Dr. C. How do you determine your patient's injection plan for PICL-2? How is it different from PICL-1? Do you share the plan with your patients? Yeah, so Vero, every single time a patient comes in, my job is to look at a couple things, right? We now have a detailed questionnaire that you get that goes over exactly what has improved symptom-wise and functionally. We also look at how much you flared after the last one. We look at other things like, did you have any problems with the anesthesia on the first one? All of these help to guide what we're doing the second time. So for example, if the patient had a major flare lasting 3 months, then we're going to be very careful about how many sites we do. Another example or another key component of that analysis is the hands-on exam. And that hands-on exam is going to help me see which additional things we need to inject or which things we no longer need to treat. So that's how that works. Vera, could multiple elbow dislocations during childhood catch up in adulthood? I also have CCI and lower neck issues, and my elbow hurts more when my neck is worse. I'm trying to figure out the cause of my elbow pain and forearm tightness, given that imaging showed nothing and I don't do anything to cause an overuse injury. Yeah, Vero, I think it sounds like you're describing a common issue that many patients have. And it's a hard one to navigate. And I'll give you an example from my history, right? I had severe back of shoulder pain. I would have bet you, this is like 10 years ago, I would have bet you $1,000 that that was caused by my shoulder. We treated, we looked at my shoulder, there was nothing going on. It was coming from my lower neck. So that was a great teaching tool for me to see, you know what? The neck can cause some very interesting stuff down in here. And you don't even know it's the neck. So it sounds like you believe there's a connection between your neck and your elbow, because when your neck is worse, your elbow is worse. And that's a common thing. So that could be, for example, you know, lower cervical nerves that go into this area that are getting irritated. Now, to answer your other question, yes, multiple elbow dislocations can cause trauma that shows up later in adulthood. But if you've had an MRI of that elbow and they're not seeing, for instance, arthritis, which is what we'd be talking about there, then really what we're talking about is just likely irritated nerves up here causing issues there, just like I had on my shoulder. I don't know your specific case, but that's sort of a general comment when I hear that. Dayron, Doc, it's unusual to have a live on a Thursday. Thank you. Thank you. Yeah, just trying to find some better work-life balance there. Dayron, I have a question. Do you recommend DMX follow-up after EPICL number 1 to see if numbers improve? And what do you think about CT scan with contrast to show ligaments, calcification, and damage? To answer the first question, we can always, at any time, do a repeat DMX. We have DMX on site at Centeno-Schultz. Not a problem, easy to do. Having said that, I have a lot of patients that are concerned about X-ray exposure, so I generally don't do it unless there's a specific reason to do it. But we can do it at any time. So just realize that, yes, we can go in and repeat that and see how things have changed. But if you ask me, I would probably only pull the trigger on it if we had a clinical question to answer. So the clinical question to answer might be, hey, we're not making much symptom progress, but did we make any progress with the instability? That'd be a great reason to take another look, because it helps with that decision matrix of, are we on the right path? Then the second question is, and what do you think about CT scan with contrast to show ligaments, calcification, damage? I don't think a CT scan is a good idea to show calcification and ligament damage. It will show if there's some calcification in the ligament, but frankly, we would see that anyway on the x-rays, and we would see that anyway on the fluoroscopy for any injection. So just realize that there really isn't a reason to use a CT scan in that particular way. There are easier ways to get that kind of info. Lindsay, is there type 3C instability, and where is this on the neck? You know, there really isn't. I think early on in that typing system, I had thought that there might be a type 3C, and that would be both extra translation and flexion and extension. But I've just sort of settled on a type 3A, translation and flexion, a type 3B, translation and extension, and kept it there. Dayron, Doc, does types or do type 1 CCI that you mentioned are better diagnosed than upright MRI? Are they treated differently when it comes to EPICL? Does getting an upright flexion extension MRI make any difference? Yeah, realize that many of the structures that we're going to treat anyway at C0, C1 are really going to be done based on your clinical history, not necessarily an upright MRI. And I'm hedging on that a little bit because there are times an upright MRI can show some really interesting things. And there are times that we'll recommend someone get an upright MRI when the DMX isn't clear or it's showing some suggestion at issues at 0-1. But just realize that if you have a DMX showing instability, you can certainly get an upright MRI, but we're sort of trying to get over that hump of whether or not someone's a EPICL candidate. And getting the upright MRI may or may not change what it is we're doing, because oftentimes we're treating at 0-1 anyway. Vero, what happens if a patient with a DMX gets PICL for certain CCI types, but other type 1s go undiagnosed? It's not having an upright MRI. Just answered that one, Vero. Kevin, hey, Dr. C, I hope all is well. Can you have crepitus in your neck without instability? What kind of joint medicine would work, assuming no instability? Thank you. Yeah, Kevin, crepitus, just to review, is kind of joint popping and cracking, right? So if you crack your knuckles, that's an example of crepitus. What causes crepitus? It's buildup of little air bubbles. And why are the air bubbles there? They can be there just because the joint is degenerative. So we tend to hear more crepitus when the joint is getting a little bit of mild arthritis, and less crepitus when it's not. Now, some people just have a lot anyway, but that's a general rule. So crepitus is usually telling us there's some mild arthritis there. It doesn't have to indicate instability. So if it's in the upper cervical spine, then we would call that craniocervical syndrome rather than craniocervical instability. And yes, we would focus, for example, on the facet joints that are mildly arthritic and causing that crepitus. Kevin, can PRP help injecting ligament and facet joints? You know, Kevin, it can. The biggest thing to focus on there is if you're going to inject the facet joints, you really need serum fluoroscopy with contrast confirmation. You can do it under ultrasound. I just can't do it well and consistently under ultrasound because you can't make sure that you're in the joint. So my recommendation would be, if you're going to get PRP injected in the ligaments, that's something that can be done under ultrasound. If you want it in the joints, it's got to be ultrasound plus fluoroscopy with contrast. And the answer is yes, it can be injected in both places. Edgar, hi, Dr. C. I'm about 70% recovered from 1 PICL and 3 cervical posterior injections at your clinic. Would you recommend stacking more treatments to keep more progress, and how far apart? Yeah, Edgar, I really can't get into your specific clinical history or any one patient's clinical guidance. I can tell you that for most patients, if you are 70% better, if that's what you're talking about, then you've really got to reach out to your attending physician, see what those functional limitations are. So for example, someone who's 70% better and pretty much fully functional, they can do pretty much anything they want. Maybe we're just moving on to rehab and calling it good. But someone who's 70% better but still has significant functional limitations, so their symptoms are 70% better, but they're creating that by living inside a pretty stout functional box, we're probably going to recommend more injection-based treatments. E. Smith, how valuable really is a static MRI that gets a good image of the CCJ, like that Crepitus protocol? Yeah, so not super valuable for me because the biggest problem is that the ligaments can look abnormal. So usually ligaments on the imaging sequences we use are dark, and you can see light patches within the ligament. But what you don't know is whether or not that ligament is functioning correctly. And to see if it's functioning correctly, we've got to load it and stretch it so that we can determine whether or not it actually works. So that's the critical piece, and that's why we like movement-based imaging. So static imaging like the Crepitus protocol isn't all that helpful for me, because while the ligament might not look great, it may function just fine. Abdu, hi doctor, I have a very straight neck and it caused brain fog and lightheadedness, and I feel my neck muscle from the back is very tight. So the question is, can a loss of cervical lordosis or loss of neck curvature cause brain fog and lightheadedness? Possibly, if it's affecting the upper cervical spine. Those are symptoms that often come from the upper cervical spine, but also realize that brain fog and lightheadedness come from many other things. So we have to be a little careful there. Mark, I have lower cervical instability shown on DMX, hypermobility in T1 and first rib and scapula. Is there any way to determine scaling muscles always tight? I was hit on the left side in a very serious car accident. Is there any way for me to determine if first rib is unstable and caused by issues, or if the first rib is moving actually caused by the scaling muscle tightness, or actually caused by the lower cervical instability? Yeah, Mark. So trying to walk that back and unpack that, is there a good way to diagnose first rib instability on imaging? Not really. Sometimes you can see some arthritis in the joint where the rib meets the spine. Having said that, we don't have good movement-based imaging tests at this point to diagnose first rib instability. Now, what's actually causing the first rib instability? Is it caused by overly tight scalings? Is it caused by the lower cervical instability? Could be either, but just realize that kind of going backwards and treating it, if you couldn't treat it conservatively with physical therapy, chiropractic manipulation, then you would try to tighten down those ligaments that hold the rib as well as the rib fascia in order to try to get better stability. But if you've got chronic tightness in the scalings yanking on that rib, and if that's coming from the lower cervical instability, then you've got to treat that lower cervical instability as well. I've had all imaging, but does not show enough to prove upper cervical instability. Pain mainly between mastoid and stellate process radiates the eye, temple, upper traps. What do you recommend? Yeah, RO, I can't give you any specific medical advice online, but what I can say is that it's pretty common to not get CCI diagnosed because the proper movement-based imaging hasn't been done. So that's very much what we're talking about this morning, right? At the end of the day, we're talking about what kinds of imaging are needed, and it's generally movement-based imaging. So for example, if all you've had is a live face up in a tube MRI or a supine MRI, that's really not going to help us get to CCI. So you could have it and it wouldn't show. So again, movement-based imaging is key. Hey, do me a favor, where you are, like and subscribe, just because that's how people find this video. And if you want to pay it forward in the CCI community, that's one way to do it. Help other CCI patients find content like this by liking this video wherever you are. E. Smith, I've heard the FDA might be changed to speed up, something more like the Australian system. Have you heard anything about this? Yeah, you know, I wish it would. I think most doctors wish it would. We would love to have more FDA-approved options for our patients. I think the FDA, it's called type 1 and type 2 error, and the FDA tends to optimize for reducing errors related to approving an unsafe drug versus the problems that could be caused by slowing down good drugs getting to market sooner. So I hope someone changes that. Who knows? Maybe it will change. Regrettably, there's a ton of institutional momentum there. There's a lot of players, everything from large universities to clinical research organizations to pharma companies who may not have a vested interest in it changing a lot because how they play the game is really built on how the FDA currently functions. So we'll see, but I hope so. What is the mechanism tied to CCI causing issues in shoulder thoracic outlet syndrome? Yeah, that's a great question. Usually it's upper cervical instability that's causing tightness in the scalenes. So those are the guy wires that are holding things up. They get tight, and then the nerves pass through those scalenes, and that's the thoracic outlet area. And then those the brachial plexus nerves get irritated, and hence you have thoracic outlet syndrome. Ashley, how Dr. Centeno, given the significant symptom overlap between hypermobile EDS, craniocervical instability, occult tethered cord syndrome, how do you distinguish when a patient's presentation warrants further evaluation for occult tethered cord? Are there particular symptoms, progression patterns, neurologic findings, or bowel and bladder changes you consider especially concerning? Additionally, are there findings you find more specific for a cold tethered cord than CCI? Yeah, so Ashley, we got to be careful, and I've said this countless times, with an occult tethered cord diagnosis in a patient with spine problems, right? For example, you might say something like, or you might see something like, well, if you have any bowel or bladder complaints and someone who's got CCI, it's a occult tethered cord until proven otherwise. The problem with that statement is if we take 100 women off the street right now who have chronic low back pain, a high percentage of them are going to have bowel and bladder problems, and they don't have any occult tethered cord. That's because if you irritate the sacral nerves, you will get bowel and bladder issues. So I think if you're talking about severe bowel and bladder issues, i.e. someone who is losing their bowels and bladder rapidly, then you're going to lean more towards an occult tethered cord diagnosis. If you're talking about sort of garden variety frequency, urinary frequency, that kind of stuff, then you got to look in the low back first, because frequently if you treat the low back in women and you treat those sacral nerves, all of that goes away without an occult tethered cord surgery. So I'm very cautious about applying an OTC diagnosis, because in my experience, most of that stuff goes away when you treat the CCI and or you treat the sacral nerves in the back. Carol, submitted advance by Crystal Brown. What is the current waiting period for CCI treatment? You know, it depends on who you're going to see. If you're asking in our clinic, if you're going to see me, it's probably a couple months out. If you're going to see Dr. Schultz, Pitts, Merkel, it's probably sooner than that. Dayron, Doc, now that the EPICL coming to Florida is halted, have you thought about taking EPICL to Cayman Clinic? Yeah, Cayman Clinic would not be a good match for the EPICL procedure. And a lot of that has to do with the infrastructure on a small Caribbean island. Now, don't get me wrong, Grand Cayman is great. It's a first world island. It's one of the only first world Caribbean islands. And what I mean by that is that the vast majority of the island looks no different than parts of the US with regard to its level of economic fit and finish. You don't see that outside of the resorts in most Caribbean islands. Most Caribbean islands, you go outside of a resort and you're in a third world country. So that's great about Cayman. But the problem is, being a small little island, it doesn't have the medical resources if there were to be a problem, in the same way that you would see in a US clinic. So at the end of the day, just realize that there's a reason why we're not doing it down there, and that's because those extra resources that surround all medical care are less common there. So Cayman would be great for doing lower acuity things rather than something like EPICL. E. Smith, do you have any sense of how common symptomatic CCI is in 1,000 people? Yeah, not very common. I would say 1 in 1,000 or less, probably less. Nikki, can a scoliosis make the CCI worse? Yes, a scoliosis can make CCI worse. And that's because anytime you have a side bend in the spine, you get rotation at the top. So it's just going to make it harder to stabilize at the top if you've got scoliosis. Okay, guys, so we're going to end a little early today. The questions have kind of petered out, and I know everyone's kind of confused. I know I'm going to get lots of stuff online saying, hey, when's your Facebook Live this Sunday? But we'll get everyone used to this new time. I appreciate the questions today. Hopefully this information I provided was helpful. And we're going to keep trying this new time to see if this works. So I'll be back next week. Oh, yeah, pretty sure next week, same time, same place. Got 2 more questions coming in here. Can PPP into the multifidus muscle and the fascial plane disrupt motor control? There wouldn't be a mechanism for that. Everything would have to have some reasonable mechanism, and I don't see how that would work, nor have I observed it clinically after injecting PPP into 1,000 patients with regard to multifidus and other muscle areas. Patricia, 48, initial stages of conservative phase, treatment for C1, C2, counter rotation, 8 months. I have no hypermobility or EDS. I have mild arthritis, loss of cervical lordosis, mild thoracic, structural scoliosis that's asymptomatic. How long for considering other interventions? Yeah, so Patricia, I can't give you a medical diagnosis or consult online. That's not fair to you or to me. I can tell you that you should, run down that conservative care path. If it's not working, then you've got to try to see if there is craniocervical instability, do the movement-based imaging, and then from there, you can make some decisions on what type of care works best. Because for us, it's got to be a CCI type, and that type will lead to the treatment. So type it first, treatment second. Okay, there's a thank you, Nathan, and a thank you for Cynthia. Well, guys, I'm going to leave you here today. Thank you so much for spending the time with me today. And I want to make sure that everyone gets used to this new time. I'll see you back next week, and we will go from there. Thank you so much.